important to know how the blood flow goes. Okay. Now, first of all, 25% of the cardiac output. Some book says 20 to 25. So let's say 20 to 25% of the total cardiac output goes to kidney. Okay. So kidney is the most important organ, actually receives the highest amount of cardiac output. This was an NBME question. I don't know if I mentioned that before. NBME had a question that they asked which organ receives the highest amount of cardiac output. Everybody picks brain. It's not brain. It's actually kidney. Okay. 20 to 25% of the total cardiac output. So how does the blood flow goes through it, right? So the way you want to think, the big picture, it's like this, right? So imagine in a schematic diagrams, it's like this. This is your artery and this is your vein. So arterial blood goes to the kidney. Some of the material get filtered, and whatever did not get filtered, it will come back to your body through the vein. Okay. Now, if you follow the arterial system, you kind of need to know that. So you have to memorize those names. So let's start here. Renal artery, that's your first branch from the abdominal aorta. And the renal artery becomes segmental artery. That means each divided go into its own segments. That segmental artery becomes interlobar artery. That means it goes to each lobe. And then it becomes arcuate artery. Arcuate means kind of curve. Now you could see that how the artery is curved, turning around, right? So that's arcuate artery. Once it turns, they are inside the lobe. So they are within the lobe. When they are within the lobe, it's interlobular artery, folks. Okay. Now this word can be confused with this one. Okay. So one is before the lobe. The other one is within the lobe. Okay. Because I was told sometime you get an options, they give you 5 options. You need to know the order. They put in a different orders. So you need to know what's the right order of the arterial system, folks. So careful with that. Okay. So once it has interlobular, then it becomes afferent arteriole. AFF, that's going in. Okay. Afferent arteriole. Then you have the glomerulus. You could see that here. In the glomerulus, we filter. In the glomerulus, we do filtration, folks. Okay. Once you do the filtration, then the blood that was not filtered, whatever did not filter, come out of the glomerulus through efferent arteriole. Efferent is exit. E for exit, they come out of glomerulus. Okay, whatever did not get filtered, they come out of efferent arteriole. Once it comes out of efferent arteriole becomes peritubular capillaries. So that's a bridge between the artery system and the veins, folks. Okay. From here, you could see the color is changing, which means the venous system starts. Now, we don't need to worry about the vein, because they don't ask question number 1. Number 2, the veins is the same name, reverse. Is that clear, folks? It's a similar name, that's reverse. Okay. So that's your peritubular capillaries. We're going to talk about a little more about peritubular capillaries. There's more to discuss about that. Now, any questions so far in the arterial system? All right. So let's go here. On the side, you could see left renal vein receives 2 additional veins. One is your adrenal gland, other one is your gonadal artery or vein, sorry. Okay, so that's something important, folks. So what does that mean? Now, so let's say this is our inferior vena cava. I'm just drawing to show, folks. Okay, that's your, this is your right renal vein. This is your left renal vein. Okay. Now, just the show, you have an adrenal gland that's sitting on top of the kidney. That's what we call it, a suprarenal gland, isn't it, folks? Now, that vein also releases in here. Okay. So the adrenal vein also goes to the left renal vein, and then they enter inferior vena cava. Okay. Now, I'm just going to show, to make it easy, a male. Okay. So if it is a male, 2 testicles is there. There's something called testicular vein, the blood that drains from the testicles, right? The right side goes directly to the IVC. Left side goes to the right renal vein. This is how it is, folks. Okay, this is important to learn. Okay, left side goes directly to the renal vein, whereas right side, they goes to IVC straight, folks. Okay, that's very important. Okay, now why do we need to know this? Sometimes we have diseases that happens in the kidney. For example, a good example I could tell is renal cell carcinoma, right? Renal cell carcinoma is one of the malignant tumors. When it happens in the kidney, it grows like this. Now you see, they are blocking all the venous drainage. Now, the left testicular vein cannot drain properly. Is that clear, folks? Because why? Because of the mass effect on the left renal vein, it's blocking, backing up the blood in the testicular vein. Is everybody clear, folks? When they back up, the vein is going to get distended. We call that varicocele. Okay, we call that varicocele. So which side has more chance to get varicocele? Always left side, right? Actually, it's almost 99% varicocele happens on the left side. Okay, very rarely it happens on the right side. Because why? For you to get right side, there has to have a massive block of the inferior vena cava, technically, which is not possible. Patient should be dead at that point. Is that clear, folks? So the varicocele always happens on the left side is because of this venous drainage that is delayed when it goes to the left side. Is everybody clear, folks? All right. Now, going back, forget about the pathology. Let's say a normal, healthy human, no renal cell carcinoma. Even a healthy people, there's a little bit of physiological delay. The blood goes here, it's delayed because why? This blood has to come, adrenal vein has to come, renal, all 3 of them are coming. There's a little traffic jam. Is that clear, folks? That's why when you check on a physical exam of the scrotum of a male, the left side scrotum is about a little bit lower than the right side. Is that clear, folks? It is anatomically normal to see a left side scrotum is a little lower than the right side. That's not abnormal, that's normal because of the physiological delay. Every human male should have left side scrotum few, not millimeters lower than the right side. Is everybody clear, folks? All right. Now, so that talks about renal vein, folks. Now, the other part, kidney has 2 areas. This is called medulla. Let me use a different color. This is called medulla. This is called cortex. You tell me, where do you see more blood flow? Towards the cortex or towards the medulla? Most of the branches are in the cortex, isn't it, folks? So that tells you cortex receives more blood flow or more oxygen than the medulla. Is everybody clear, folks? So that means even in a healthy people, renal medulla receives significantly less blood flow than the renal cortex. This makes medulla very sensitive to hypoxia, which means in the event of hypoxia, medulla will die first, then the cortex. Is everybody clear, folks? Every organ we have seen one area that gets more blood flow and one area that gets less blood flow, right? If you remember liver, zone 1 get highest amount of oxygen, zone 3 gets lowest amount of oxygen, isn't it, folks? So if I ask you in the event of ischemia, zone 3 dies first. Same thing in the kidney, medulla will die first. Is everybody clear, folks? All right. So that's that. And when it comes to kidney transplant, usually they take the left kidney because the vein is long and that makes it easier for surgeon to do the surgery, folks. Okay. So that's renal blood flow, and that's your gross anatomy. Any question for me? All right. Now, let's go to a little bit of glomerular, folks. Okay, this is a histology. Now, before we go to glomerular, we need to know the terminology is clear. What's the difference between glomerular?
I didn't really understand. Like, what does the surgeon
So what happens is the left kidney has longer vein. So the vein is longer, so it makes it easier for surgeon to do the surgery because they have to cut it and place it. So the longer the vein, the much easier for them to do the surgery. That's all. And I don't think you will ever get a question, but in case if they ask, that should be your left side, okay? Now, when it comes to kidney terminology, glomerulus, but then we also use the word nephron. If I ask you, what's the functional unit of the kidney? The functional unit of the kidney is nephron. Is that clear, folks? That's why when you have a problem with kidney, you go to nephrologist. You don't go to glomerologist. There's nothing like that, okay? So you go to nephrologist, right? It's very important. So what is nephron and what's the difference between glomerulus? Nephron is actually glomerulus plus the tubules. They put together. So the glomerulus and the tubules, your PCT, DCT, collecting duct, all these things, right? All the tubules and glomerulus together, we call it nephron. Is everybody clear, folks? Here, they are just talking about glomerulus. They are not talking about the tubules, okay? So if I write glomerulus plus tubules, that's your nephron. You should be very clear with the basic definitions, folks, okay? So that also tells you when you go to a nephrologist, they would only treat the condition that happens in the glomerulus and tubules. Does that make sense, folks? What is after tubules anatomically? Ureter. Okay, that's your ureter. The minute pathology touches the ureter, you go to urologist. Is that clear, folks? So that's a different, okay? So glomerulus and tubules is called nephron. Now, here there is one glomerulus they have shown, folks, okay? There's so much here you could learn. Anytime you look at the glomerulus, first identify yourself with afferent and efferent, because not always afferent is in one side. Each diagram can change it. Look at this here, afferent on the top, efferent, right? If you go to the next page here, for example, afferent is also here and efferent is this side. But there could be another diagram that structures on the other side. So it could be anywhere you want to draw. So you have to pay attention to afferent and efferent, folks. Okay, that's important. So here the blood is coming in and they come inside. In this glomerulus, they have filtration. So when we say filtration from here, we filter the substances that we can filter. Don't worry about what we filter, that we'll talk in the physiology, okay? So we filter. When you filter, that's basically technically getting into the tubules, which eventually becomes urine, because this end product is urine. Is that clear, folks? So that get filtered. Whatever do not get filtered, they go back here. They are going into the efferent arteriole through peritubular capillaries, and finally it will come to IVC. So technically, if I inject a dye on the afferent arteriole, after a few hours, I should see that same dye on the IVC. Is that crystal clear, folks? It should come out, folks, okay? So that's that, number one. Number two, to pay attention. Now, in kidney, let's learn three terminologies. Filtration, reabsorption, secretion, and excretion, fourth one, okay? These four terminologies should be fingertip, because that's the last thing you want to be confused with. Filtration means what are the substances get filtered in the glomerulus? Substance that get filtered in glomerulus, okay? The substance that get filtered in the glomerulus, folks, okay? Anything that you filter. When it comes to reabsorption, you are absorbing from the urine, putting it back in the blood. So these are happening in the tubules, okay? Now, for example, here, this is a discontinuation. This is if you were to continue, that's your PCT. Sometimes you could reabsorb from the urine back to the blood. Is that clear, folks? That's called reabsorption. Reabsorption means urine to the blood. You need to know how it happens. We'll talk about that in a moment. Secretion is opposite. From the blood to the urine. From the blood to the urine. Now, keep in mind, There are two ways you could get the substance from blood to the urine. One is by secretion. The other one is by filtration, because remember, when you filter, that also technically goes from blood to the urine. Does that make sense, folks? There are two ways, okay? Now, finally, the last one, excretion. That's actually how much you excrete in the urine, because not everything you filter are excreted. Because sometimes we filter and then we also reabsorb on top of that. Is everybody clear, folks? So just to know hypothetically, let's say I'm filtering 500 ml. Don't think you will excrete 500. In that 500, you may reabsorb 100, and then you may only reabsorb, excrete 400. Does that make sense, folks? So just to know, filtration should never match excretion. Is everybody clear, folks? All right. Okay. So don't get confused. But other than that, that's the four terminologies. Are we clear with that? Okay. Now, I want to show you a different picture, okay? See, this picture has what we needed. They are showing what is filtration, and they are showing what is reabsorption, you see, from the urine going back to the blood. And secretion means going from blood to the urine, and then finally you have excretion. So everybody clear, folks? All right. Now, this picture shows the continuation of efferent arteriole, and look at that. That's your peritubular capillaries. Now, when we say reabsorption and secretion, it is actually between the tubules and peritubular capillaries. Is everybody clear, folks? It's between the tubules and peritubular capillaries. This is something most of us missed during medical school for some reason. Peritubular capillaries travel parallel to the tubule. Wherever you have tubules in the kidney, the peritubular capillaries will travel along with them. Does that make sense, folks? Now, let's draw a sample one here, right? Just to kind of understand that. So let's say, okay. So this is glomerulus, okay, for me. That's my afferent arteriole. This is efferent arteriole. That means blood enter the kidney through here, folks. Is that clear, folks? So this is your tubule, okay? Now I could tell you this tubule goes like this and all these different way. Ankle goes up and down and all these things. I could tell however I want. This is a continuation of efferent arteriole, what we call peritubular capillaries. Is that clear, folks? I'm just showing it in one line. It also travels parallel to the tubules wherever the tubule goes. So the reabsorption and secretion can happen. Is that crystal clear, folks? So anywhere you see kidney tubules, right behind you will see peritubular capillaries. Is everybody clear, folks? So that's very important, okay? Now, this diagram is not the perfect diagram, but let me erase this. Histologically, one of the best way to identify afferent and efferent, okay? So let me finish this here, folks. So you see here. So always remember the tubules. It's not straight down. It goes down and up and stuff, right? So if I were to draw, it comes back like this, okay? It comes back like that, for example. I'm going to name this area as DCT because this is PCT, thin ascending, thick ascending, all these things are there. I want you to remember DCT is very close to afferent arteriole in histology. Now, if you go back to this picture, look at this picture. This is your DCT. You see that DCT is next to afferent arteriole. DCT is always next to afferent arteriole. Now, people get confused. How did I get DCT there? I want you to be very clear. This structure is a continuation of this. Is that clear, folks? It has turn and comes up. Is that clear, folks? It's like a wire. It comes down, cords, it goes up. So here, if you think this is PCT, I could draw all the way down and then they will come back up. Is that clear, folks? They come up and down. So you should always know DCT is right next to AFF. Let's go to the first diagram. So in histologically, if I don't give you this name, how do you know which one is afferent, which one is efferent? You look at the DCT and whatever it's always next to it, that's your AFF. Is everybody clear, folks? All right, very good. Now next,